Assalamu alaikum wa rahmatullahi wa barakatuh. Renal pain evaluation. Objectives. We try to take appropriate history, focus history taken, conduct local examination, provide provisional diagnosis, order specific investigation for each case, and propose appropriate plan for further management. Case study. A 32-year-old male patient with acute right flank pain presented to the emergency department. Question number 1. List the differential diagnosis of right loin pain. It may be musculoskeletal, kidney stones, acute pyelonephritis, GIT disorder, gallbladder disease, pneumonia, right basal lobe pneumonia, salpingitis, herpes zoster, and others. What's this? This is a rash from herpes zoster infection, usually presented with pain which simulate the loin pain. Question 2. How would you analyze loin pain? We analyze loin pain usually by take appropriate focus history taken. Pain due to inflammation. We had two types of renal pain. Pain due to inflammation usually steady in nature, while pain due to obstruction usually colicky in nature. Pain of renal origin is usually located in the ipsilateral costovertebral angle just lateral to the sacrospinalis muscle and beneath the 12th rib. The pain may radiate across the flank anteriorly toward the upper abdomen and umbilicus and may be referred to the testis or labia. It actually depends on the site of obstruction. Urethral pain. Urethral pain is usually acute and secondary to obstruction. The pain results from acute distension of the ureter and by hyperperistalsis and the spasm of the smooth muscle of the ureter as it attempts to relieve the obstruction, usually produced by stone or blood clot. Thus, the pain produced by urethral obstruction is typically colic in nature and intensified with urethral peristalsis, at which time the pressure in the renal pelvis rise as the ureter contract in attempt to force urine past the point of obstruction. Always, we should consider the possibility of renal tumor in patient presented with a gradual onset of persistent pain, which may be associated with visible hematuria and mass. Beware of older patients with history of hypertension, smoking, or hypercholesterolemia who may present with renal colic pain due to dissecting abdominal aortic aneurysm. So, temperature, pulse rate, and blood pressure should be checked always. Urine analysis should be performed to look for red cells, white cells, and nitrites. Radiation of the pain may detect the site of obstruction. Pain radiated to the anterior abdominal wall. The obstruction may be in the renal pelvis or at the level of the upper ureter, while pain radiated to the right lower quadrant of the abdomen. On the right side, we think about the appendicitis, while on the left side, we usually think about the diverticulitis as a differential diagnosis of loin pain or urethral pain on those sites. So, pain may be referred to the scrotum in the male or labium in the female. And the obstruction usually occur because the stone usually lodged at the intramural part of the ureter. Lower urethral obstruction frequently produce symptoms of vesical irritability, including frequency, urgency, and suprapubic discomfort that may radiate along the urethra in men to the tip of the penis. GIT symptoms and fever, which are the main associated symptoms of renal pain. The GIT symptoms may occur due to stimulation of the celiac ganglia and because of the proximity of the adjacent organs like liver, pancreas, duodenum, gallbladder, and colon. How we take focus history? Usually we concentrate on some important things like during history taking about the self-introduction, permission. We should ask about the duration of pain, site of the pain, gradation of the pain, nature of the pain, associated symptoms like fever and GIT symptoms, severity of the pain, and how we can detect the severity of the pain by interference with the daily activity and by applied the visual analog score of pain. We should ask the aggravating factor and the relieving factor of this pain. By physical examination, we should perform and communication skills like introduction, explanation, permission, exposure, inspection, palpation, auscultation, and finally we should track the patient. Inspection for any scar, any mass, any uh, catheters, evidence of distension or visible masses, any rash, palpate the abdomen for superficial tenderness, deep tenderness for deep palpation for any masses, renal angle tenderness, and deep palpation for any organomegaly by manual examination of the kidney, by placement of the one hand on the costovertebral angle, while the other hand usually as a palpating hand, percussion of the abdomen, and finally auscultation of the abdomen by placement the stethoscope 1 cm or 1 inch, which is 2.5 cm above and lateral to the umbilicus. This, this examination, usually we took it in detail in our virtual session and we applied it practically on the patient. This is pictures of my manual kidney examinations. Look for this hand usually placed at the costovertebral angle. And this hand usually a pushing hand, while this hand usually is a palpating hand, while the patient taking a deep breathing, usually you try to palpate the kidney and we try to palpate and to feel the lower edge of the right kidney. Actually, palpation should be started from the right iliac fossa for the right side and from the left iliac fossa for the left side. Why? Because sometimes the kidney get more enlarged more and the mass get down to the iliac fossa. So you should start palpation from this side. This is a case study. This is a question, practical question. What is the best imaging modality for the patient? As we learn, an enhanced or helical CT is the gold standard of initial diagnosis with a sensitivity of 98% and specificity of 100%. Look for this CT scan view. This is a CT scan, which is non-contrast, spiral, conventional CT scan, cross imaging. This is the right kidney, and this is the left kidney. What this? This is a stone lodged at the side of the upper ureter or the PUJ, pelviureteric junction. This is an obstructing stone. How can you clinically differentiate between a pain of urological cause from a pain of peritonitis? Pain of intraperitoneal origin is seldom colicky, as with obstructive renal pain. Furthermore, Pain of intraperitoneal origin frequently radiated into the shoulder because of irritation of the diaphragm and phrenic nerves. This does not occur with renal pain. Typically, patients with intraperitoneal pathology prefer to lie motionless to minimize the pain, whereas patients with renal pain usually are more comfortable moving around and holding the flank. So, when you see the patient which is rolling around and try to move to decrease the severity of the pain, this is a typical pictures or presentation of loin pain. This is a practical question. Another practical question, a small lower ureteric calculus with associated mild hydronephrosis was identified in this patient, and he was prescribed pain medication and discharged to pass the stone naturally. So this patient, إذا نتذكر, our patient, 32-year-old patient, presented to the casualty with right flank pain. By CT scan, there was a small lower ureteric calculus with associated mild hydronephrosis was identified. So our decision to put the patient on conservative treatment. So what is the preferable type of analgesia? And what are the cautions with this type of analgesia? This is a protocol called MET protocols, which is medical expulsive therapy. MET protocol, medical expulsive therapy. The preferable analgesia is a non-steroidal anti-inflammatory drugs, which decrease the production of arachidonic acid metabolite, which mediate pain receptor, elevating pain caused by distension of the renal capsule. What are the questions about this type of analgesia? Usually hypertension, uremia, gastric or duodenal ulcers, pregnancy, all of those are cautions for such type of analgesia. Parenteral non-steroidal anti-inflammatory drugs such as ketorolac, which is 15 milligram to 30 milligram intravenously or intramuscularly, or diclofenac, 37.5 milligram intravenously, are most commonly used. Opiates. Opiate pain medication such as morphine sulfate, 0.1 milligram per kg intravenously or IM, or hydromorphine 0.02 milligram per kg IV or IM, can also be used effectively for analgesia, especially when other measures have been failed. However, opiates are associated with respiratory depression and sedation, and there is a risk of dependence associated with prolonged opiate use. Other measures, fluid hydration and addition of medical expulsive therapy like alpha-1 adrenoreceptor blockers exist. The use of alpha blocker medication, for example, tamsulosin or nifedipine, is theorized to facilitate stone passage by decreasing intraureteral pressure and dilating the distal ureter. There is alpha adrenergic receptors exist in increased concentration in the distal ureter. So by blocking of this adrenergic receptors, there will be a passive dilatation of the intramural part of the ureter, and this will enhance spontaneous stone passage. So this a CT scan of this patient, and this is the stone lodged to the lower part of the ureter, and this is the kidney, and we can see the dilatation of the renal pelvis of the kidney. This patient returned back with intractable pain. CT scan was shown above. This is the CT scan with this patient, but the patient returned back, not improving on conservative MET protocol medical expulsive therapy. The patient become more symptomatic. Okay, so what are the indication for surgical intervention in such patient, and what is the preferable type of management? The more the indication in such case is the intractable pain, and the best management protocol for this patient is by performing a ureteroscopy procedure because the stone in the lower ureter. If the stone in the upper ureter, shockwave lithotripsy is the best procedures, but because the stone lodged in the lower ureter and because there is limitation for extracorporeal shockwave lithotripsy in this site because of bony alignment of the patient can prevent localization and proper fragmentation of the stone by usual technique. So ureteroscopy procedures may be the best option for this patient. So ureteroscopy with either laser or electrohydraulic stone fragmentation is the best protocol for this patient. Sometimes we need placement of double J stent or percutaneous nephrostomy may be used to help the urinary drainage of the affected renal unit while the definitive stone therapy postponed until the patient is stable. This picture showing the stone fragmentation by lasers. This is the ureter, and this is the stone fragmented by laser, intracorporeal laser therapy. Question: what are the measures that decrease recurrence of stones? We have a lot of measures listed in this slide to decrease the stone recurrence rate, like behavioral modification, increase fluid intake, use some medication specific to the stone types, like thiazide diuretics, allopurinol, potassium citrate, and usually and change the dietary pattern of the patient specific to the stone types, like for patients with hyperoxaluria should be encouraged to lower their oxalate intake by limitation of some food product like chocolate, green leafy vegetables, nuts, and spinach. Case number 2, we have a patient called Saham Kadam Hussain. She is 45 years old. The chief complaint was left colicky loin pain for 2 weeks duration associated with low-grade fever. There is no history of previous similar attacks. Past medical history, no significant past medical history. Past surgical history, history of laparoscopic cholecystectomy 5 years ago. Drug history, no history of drug allergy or drug intake. She was not a smoker at all. Investigation reveals microscopic hematuria and UTI. Renal figures was blood urea 48 and serum creatine 1.5 milligram per deciliter. The hemoglobin was 10.1. CT scan findings of large, big left renal stone. This stone usually located on the renal pelvis. And this is the ultrasonic features. This is the kidney, and this is the stone. And we can see if we concentrate the echogenic shadow coming from the stone. This is the stone, and this is the echogenic shadow of the stone. This is the CT scan showing the left kidney, usually decreased parenchyma, hydronephrosis, and big renal stone, occupying most of the pelvis of the kidney. We did it a PCNL procedure, which is the best procedure for such big renal stone. And the stone was fragmented and retrieved outside the kidney. This is some important procedures. You can follow it on YouTube's like PCNL procedure and ureteroscopy procedures. Quiz: ureteral stent placement when shockwave lithotripsy is performed for ureteral stone is appropriate for all of the following reasons except A. Solitary kidney, B. Relief of severe symptoms, C. Enhancement of stone fragmentation, D. Relief of obstruction, E. Aid in localization of difficult to visualize stones. What is the best answer? This is for you and for discussion panel. Explanation: answer is C. Routine stent placement before shockwave lithotripsy was discouraged. However, ureteral stent placement is appropriate for other indications such as management of pain, relief of obstruction, and stone that are difficult to visualize, and is mandatory in patients who have a solitary obstructed kidney. Thank you very much. دكتور سعد داخل. السلام عليكم ورحمة الله وبركاته.